All right, so here we have a case of a 26-year-old female. She's dizzy. She got some heart palpitations. And this is all going down during finals week where she's been drinking lots of energy drinks. There they are. So this is a pretty interesting case because this is going to be a narrow complex tachydysrhythmia. We know it's a narrow complex tachydysrhythmia because the QRS complexes are narrow. They're less than 120 milliseconds. It's a tachydysrhythmia because the rate is somewhere in the range of 150 beats per minute. And we can tell that that is the rate, again, just because if we measure the big boxes and then divide 300 from the amount of big boxes that we see, which is going to be 2, that'll give us 150. So what's pretty interesting about this case is that when you really kind of scrutinize each individual complex, you'll notice that there's a little bit of weirdness associated to the QRS complex and the resultant T wave. We've got this kind of peculiar little blip here, and I think if you are picking up on that, it might be throwing you off a little bit. And so when we are confronted with a situation where there are a lot of options and we're not really sure what to make of it, we can formulate a real quick differential diagnosis to try to give us an idea of what we're dealing with. So anytime we have a regular narrow complex tachycardia, our differential is going to be quite simple. First on the differential, sinus tach is usually a cause of regular narrow complex tachycardias. We have a flutter with 2-to-1 conduction. That's another common cause of regular narrow complex tachycardias. And then we have our AV nodal reentry tachycardias. The blanket term for this one is usually referred to as SVT. So in order to figure out what this is, we're going to need to start taking some of the criteria that either rules in or rules out these differentials that we have here and seeing if it matches up. So when we're thinking about whether or not this is sinus tachycardia, in order for something to be a sinus tachycardia, we need to have a pretty regular P wave activity preceding each QRS complex. So it gets a QRS complex, we'd expect to see a P wave occurring at fairly regular intervals right here. And we don't see that. We do, however, see this right here, and that is in fact a P wave. However, we know it's not a sinus-produced P wave in the sense that this is a sinus rhythm because the distance is way too far for the rate. So we can take sinus and we can cross that out. It's not going to be a sinus rhythm. Next on our differential is going to be atrial flutter with 2-to-1 conduction. Now this is an instance where it could get a little tricky as far as determining whether it is in fact a flutter or 2-to-1 or it is AVNRT. And this is why. So with a flutter 2-to-1 conduction, usually the atria are beating between 250, 300 times a minute, and that then produces a rate that kind of sits pretty regularly at 150 beats per minute. You would also expect to see some degree of flutter waves, and thankfully in this example we really don't see that. In fact, we see some atrial activity, but it's not at a rate of 300 times a minute. It seems to be more at a rate of maybe 150-ish. If you were to map this little atrial beat or little P wave to that one, we would see that the distance between those two is about the same at 150. So we can take a flutter off of the list. Finally, we are left with AV nodal reentry tachycardia, and that's going to be our diagnosis for this particular strip, mainly because we've got regular R to R intervals. And so if we were to take these two R waves and map them out, essentially, then you would see that they do have almost identical distance from one another, which is a sign of AV nodal reentry tachycardia. Additionally, there are no P waves preceding each QRS complex. And you might ask yourself and say, well, Garrett, you said that these things right here are P waves. Wouldn't that be preceding a QRS complex? And, you would be kind of right in the sense that this does precede this. However, what you're seeing here are actually retrograde conductive P waves, meaning that within the heart, the impulse is originating at the AV node. traveling down the left and right bundle branches, but also going back up to what would be the SA node and causing a atrial depolarization. And that retrograde depolarization of the SA node is what is producing these P waves, which are occurring after the QRS complex. And so this is a retrograde P wave, and it is not and it can be affiliated with AV nodal reentry-tachycardias, and that's what this rhythm is. What we're dealing with here is AVNRT.